Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about autoimmune diseases that can cause someone's platelet to be too low. When I left off last week, I was talking about a condition called TTP, thrombotic thrombocytopenic purpura. In this segment, I'm going to give you a final overview of what really TTP is. It's a very common problem. In this country, is one person per every 100,000 individuals known to have TTP. Across the world, is 4 individuals for every 100,000 folks known to have TTP. And as you know, there's 7.7 billion people in the world. And of course, in this country, the latest stats is that there are 329 million folks in this country. Okay, so it's a serious problem. And it is an autoimmune disease. And I'm not going to confuse you by going into too much detail, but suffice it to say, most of the time, the mechanism that causes TTP to occur is because of the inhibition of an enzyme called ADAPS TS13, which is a metalloprotease responsible for cleavage of large multimers of von Willebrand factor into smaller units. This is the basis. Okay, I'm not going to get any more detail and get you confused. Suffice it to say, the organs that are most affected by TTP because the platelet is low, of course, is the kidney, the brain, the heart, and the blood. You say, well, how so? Well, what makes TTP such a bad thing is that the platelet, the total platelet being low is not the issue. So there are hundreds of conditions that can cause one platelet to be low. The problem is, in this setting, it's not a bleeding problem. It is a clotting problem, even though the platelet may be 10,000, maybe 20,000, maybe 25,000. Of course, you could bleed if somebody caught you, but spontaneously what's going on is that the platelets aggregate into little clots. And those little clots then clogged up blood vessels in the brain, in the kidney, in the heart, and in the blood. If it clogged up the kidney, then you wind up having kidney problem, and the kidney can in fact fail, and it has been known to fail. If it affects the brain, you could have a stroke. You could have a seizure because the area is not getting blood and it becomes ischemic. You could develop a seizure because of that. If it occurs in the heart, which it often does, then you could obviously have a heart attack and all the complications thereof, including cardiac arrhythmias, congestive heart failures, and so on and so forth. And what is most commonly occur, of course, is in the blood, because when it occurs in the blood, it can also be associated with hemolysis. The hemolysis occurs because of an autoimmune phenomena. It also occurs because as the red blood cell by necessity must pass through blood vessels. But the blood vessels are clogged up, many of them with those little platelet plugs, and the red blood cell is forcing its way through to go around to do its job, which is to deliver blood and oxygen. That passage, forcing in the passage area, cause the red blood cells become chopped up. A series of blood cells we call schistocytes. Now, this is the key. Of all the things that I'm going to discuss with you, the thing that to take home with is the fact that when somebody suspects that you have TTP, then you have to compare it with other conditions that can cause low platelet. It's an infection, because in the hospital setting, the most common cause of low platelet is an infection. The second most common cause of low platelet in a hospital, of course, is DIC, disseminated intravascular coagulopathy. But stay there. Just stay there for 1 second to tell you how important it is to have thorough knowledge of academic clinical medicine. Right there. The list of things that you could do to diagnose the situation? Let me list them for you, and I'll tell you what's the easiest way. You're obviously going to do a physical examination. You're going to do a blood count. You're going to look at the blood smear, complete metabolic chemistry profile. You're going to look at the LDH, because if somebody is hemolyzing, the LDH become elevated. You do an incomplete bilirubin. If somebody is hemolyzing, the incomplete bilirubin can be high, but can be high, not always, because if the liver is good enough, the liver will be able to get rid of the bilirubin, and so you could be very careful with that. You do a direct Combs test to make sure they don't have an autoimmune hemolytic anemia or direct Combs test going positive. You do a haptoglobin. You do a reticulocyte count. You do a PT, PTT, RNR. You're going to do urinalysis, chest X-ray, renal ultrasound, EKG, EEG, brain CT, brain MRI, etc. But look at the test that I just said. I just said you're going to do a PT, PTT, RNR. What is this all about? Well, because if the person has DIC almost always occur in the setting of a hospitalization when somebody is very, very sick. But you must be certain you know on how to differentiate between DIC and TTP, because the management is different and the general outlook of the patient outcome is also different. Well, how do you do that? Well, if you have DIC, your PTT is likely going to be elevated. Your platelet is low, your PTT is elevated. That's sort of a red flag leaning you toward DIC. On the other hand, if your platelet is low, your PT and PTT are normal, right away the red flag should raise toward TTP. What do you say, how so? Well, what you do at that time, then you walk to the clinical laboratory and ask the technician, can I please take a look at the smear, blood smear of Mr. or Mrs. So-and-so, or Miss or whatever, so-and-so, to look at under the microscope. How about that? If this patient which has normal PT, normal PTT, no coagulopathy at all, and yet the platelet is low, and you find schistocyte when you look at the blood smear, you have just diagnosed this incredibly complex, complicated condition, TTP. That's right. Because as the red blood cells are passing through, because the vessels are clogged up with those little platelet plugs, the red blood cells get damaged. Because they get damaged, you're going to have hemolysis on the one hand. You may also have hemolysis because there's an autoimmune phenomena associated with it, and or the breakage of this red blood cell occur. Now, this is not a $10 million machine. This is just the brain over your shoulder, and you know enough to walk to the laboratory, and you just make a diagnosis that can probably save the patient's life and save thousands and thousands of dollars of wasteful tests. Wasteful tests. That, I mean, I just mentioned, look at all these tests. Look at the EKG, the EEG, the brain CT, the MRI, and all this other stuff. Those are expensive things. But if the patient is not having any of these symptoms, seizure, any chest pain, any cardiac arrhythmias, and you just diagnose TTP, what's the sense of doing all these things? The patient don't have those symptoms. Why throw this money away? For what? You just made the diagnosis. Just because you didn't spend thousands of dollars to make the diagnosis doesn't mean the diagnosis is not just as important and just as correct. Now, I want you to understand, I'm not saying anything negative about this CAT scan, about this MRI. I order them all the time. We all do. But it is not always the best thing to spend the most money to make the best diagnosis. Because you have to remember something. as I get involved this past week in discussions with colleagues at the hospital up the street, 70 to 75% of physicians who practice medicine do every day is based on two things: knowledge and experience. So therefore, there's no room in clinical medicine that you're doing daily to be sticking on to protocol. That's in a research laboratory. I'm not against protocol. It's a research laboratory. I did research in the laboratory myself. In fact, that's how I get into medical school, because the stuff that you see on television nonstop all day, all night, dealing with Humira and all this other stuff. I didn't do those particular stuff, but I did the original research using a medication called methotrexate. And across the world, methotrexate is still being used to treat this very same thing every day, because people cannot afford these other expensive medication. They're fantastic medication, but they went to the laboratory via DNA recombinant technique, created them because of the toxicity of methotrexate. I did that. This is how I'll be able to sit here talking to you as a physician. That's what got me into medical school. I was a lowly medical technologist at Brookdale Hospital in Brooklyn when I was allowed to do my own little research in the laboratory of a doctor who was very kind to me, who allowed me to do my own research, because the two hematologists that were in training during the last year of research were not interested. They were just coasting along to finish the year to go about their business. And my boss hired me basically to teach them how to do the research project via technical way of it. They were not interested. And he, being the smart man that he was, he politically realized what was going on and said, Val, you could do your own research if you want to. And out of the top of my head, I came up with the idea how to do this research, and the rest is, of course, history. So I have nothing against laboratory research or protocol. But when you're talking about clinical medicine, that's a different story. You have got to change things from moment to moment. It's a little bit of this, a little bit of that. Clinical medicine is an art form based on science. Those who are just sticking to protocols, stay away from them as far as you can, because you need clinical judgment to practice the best medicine. And I couldn't care less what anybody say or think. That's the reality. They don't like what I say, that's their problem. Tell them, go and get a professorship at Einstein, get a professorship at New York Medical College, and get a mastership from the American College of Physicians. Then they can come and sit here and say, Val, I disagree with you. If they can't do that, then shut up and try to learn some stuff. So now that you suspect that this patient have TTP, but the patient is doing fine, there's no seizures, there's no this, there's no that, then your job then is to try to treat this patient. That's right. And as I mentioned before, the number one treatment across the world to treat autoimmune diseases and thousands of other diseases happen to be steroid. And as I mentioned again before, and I'll mention it again, it's a Dr. Percy Julian, a Negro gentleman who lived right here in Greenburgh, New York, died at age 76, who invented, created, biosynthesized corticosteroid and left it for the world as we know it. And most present-day physicians who are using steroid 24/7 they never heard of Dr. Julian, because he's a Negro. He couldn't even get to do his PhD in America, his own country. He had to go to Scotland to do it. And when he came back, he left a whole lot of stuff behind for the world. One of them is steroid. And if you were not a Negro, you will hear his word all the time. You want to find out all the stuff that he did? The New York Times wrote this incredible article about him when he passed away. You could Google it. Pages of all the stuff that this man had done. So steroid is one medication that can be used. You could use Cytoxan. You could use vincristine. But nowadays, the most, besides steroid, the medication that's being used most frequently is Rituxan. In addition to Rituxan, you could also give the patient aspirin. You say, well, how can you give a patient aspirin when the platelet is low? Yes, you can, even though the platelet is not a bleeding issue. It's a clogging issue, coagulation issue, clotting issue. And aspirin will dislodge those little plugs that are inside the blood vessels to allow blood to go through and then release all the stress on the kidney, the brain, the heart, etc., and the bloodstream as well. And the steroid will dislodge the antigen antibody processes that's going on, allow the platelet count to go back up. And the toxin will do the same thing. The toxin will do the same thing quicker and has less side effect than steroids. Steroids is fantastic, but you can't use it chronically without developing a lot of side effects, so on and so forth. So, Rituxan. And if acutely, the patient is acutely sick, you really have to do something, you could do plasmapheresis. That's right, remove plasmapheresis, which is a way of removing the bad blood from the patient and put new plasma in and so on and so forth. You could do that acutely. Somebody is acutely sick, they're seizing, they're about to have a heart attack, and you could do plasmapheresis quickly to intervene to relieve the stress on the body, and that would help. And because the patient is hemolyzing, you give them folic acid. Well, you say, how does folic acid get into play? Well, you can't be hemolyzing without being folate deficient. You say, well, how come? Well, when you are hemolyzing, part of the hemolysis process causes you to be using folic acid non-stop to try to replace the red blood cell that you are destroying. So therefore, everyone who's hemolyzing, by definition, folate deficient. What you must remember, however, is that 1 milligram of folic acid is good for nutritional purposes, to replace folic acid nutritionally. However, somebody is hemolyzing, you need large doses of folic acid, sometimes 20 milligram. The maximum dose recommended is 25 milligram per day. That's right. And if you just give 1 milligram of folic acid to someone, you're wasting your time because it's not enough. Okay, so you have to remember that when somebody is hemolyzing, you start with 4 milligrams of folic acid 4 times a day. That's 16 milligram. That gets you rolling. You have to keep up with the fact that the patient is hemolyzing. If you don't understand that, that is basically your problem, not mine. And sometimes patients wind up with kidney fail acutely. You have to do all the stuff you're doing, but you also have to dialyze them. To keep the kidney going, and the kidney sometimes return. After dialysis, after you treat all this pressure, the kidney function sometimes returns, sometimes it doesn't. If it takes you too long to make the diagnosis and the kidney was affected, this patient may wind up with chronic kidney failure. But if you were aggressive enough and intelligent enough to know what you were dealing with, and you quickly step in. See, you got to understand something. It's not the condition somebody presents with may not be the underlying reason they have the problem. That is why you need a wide range of knowledge. Let me repeat that. You need a wide range of knowledge. What people consider little thing may not be little thing. It is the little thing that may save the day. Because somebody shows up, they were minding their own business, all of a sudden they show up to you, they're not feeling well, the kidney is failing in the emergency room. Well, patient, it could have been because they're diabetic, it could have been because they're septic, it could have been because they went to shock, it could have been a lot of stuff. But the patient showed up here, they're afebrile, they have no evidence of an infection, and the kidney is failing. The blood pressure is perfectly fine. They have no history of blood pressure problem, no history of diabetic problem, and all of a sudden they have low platelet count, and the kidney is failing. That should make you suspect right away, why should this patient platelet be low and the kidney is failing? If you have a wide range of knowledge, right away your red flag should go up. Oh my goodness, I bet you this patient has TTP. But where are you going to come up with that idea if you don't even know what TTP is? You never heard of it. And then you're running all over the place, doing all kind of stuff. When the stuff is staring at you right in front of you, staring at you right there, but you don't understand it. You're saying that, and take days before you call someone else and to consult. By the time the person comes in, he or she realizes that this was TTP. That is a week later, and the kidney function may never return. But if you have enough wide range of knowledge, the so-called minutia, maybe the thing that saved the patient's life, saved the patient's kidney. There's no such thing in clinical medicine as minutia. The people who think there's such thing is because they don't know what they're talking about. This is why if you just look at the big picture, take a look at it. Review the chart. Take the history. The answer may be right there under your nose. Okay, of course the complications are you have to give the patient anti-seizure medication, treat the stroke, treat the angina, treat the congestive heart failure, heart attack, whatever that you're dealing with. And lately there have been a medication approved by the FDA called Caplasizumab. Caplasizumab, that is approved by the FDA to acutely treat this medication. This is something new, okay? And I'm not going to tell you the stuff that I have in my hand is in a big book that I'm writing, and I won't name the name of the book. So it is you basically being privy to the latest of all the latest thing you can get your hand on having to do with TTP. That's all I'm going to say about it. So therefore, then, I've given you all this stuff. This is the 10th show that I'm doing dealing with autoimmune diseases associated with white blood cell, red blood cell, and platelet, okay? And keeping in mind that I'm not done yet. I think I have one more to do before I close up the series. And that one, so therefore TTP then is a very common problem. A lot of people don't recognize it. It goes on undiagnosed because they don't understand certain nuances that will give you, raise the red flag. Somebody coming with a stroke, the stroke may be a stroke, but there may be a reason, maybe TTP. Somebody comes in with chest pain. The chest pain, you do the usual stuff, which you have to do to make sure patient that have a heart attack, you intervene. But take a look at the platelet count. Platelet count is low. Somebody's having chest pain. How do you go from chest pain to low platelet? Patient may be having TTP. And if you know what to do, you intervene quickly. By the way, this is going to be shocking to you. One of the medication can cause TTP, okay? Across the board, people are throwing Plavix, which is a great medication. Everybody, you can't have something associated with your heart without somebody putting you on Plavix and aspirin. Now they finally now come up with the conclusion this is not the. I've been saying it for God knows how many years now. Finally, the powers to be realizing that it really not necessary. You can't make this up. I mean, years you heard me literally banging these people for doing that. And now, finally, they realize that you're causing more bleeding than is necessary. And medication can cause TTP. Guess which medication? Okay, which of the medications that can cause TTP? Are you ready for this? Plavix. How about that, okay? And you can't sneeze with anything happening with your heart in this country without people putting you on Plavix. I'm just telling you, Plavix can be associated with TTP. How about that, okay? So you got to be very careful. Very careful. Clinical medicine is fantastic, but it's no fun. If you don't know it enough, it's extraordinary amount of brilliant, excellent, outstanding physicians out there I'd be more than happy to come and help you out. But to somebody is the sickest, when the sicker they are, they need the best doctor at the bedside to take care of them. That's it. And I've been a patient. Let me tell you, I've been a patient. And I'm going to continue to advocate for patients. And I couldn't care less how many attempts have been made using all kind of crazy nonsense to do bad things to me because I talk a lot. Well, that's their problem. The fact is, I've been a patient, and I know what it feels like to be on the other side. So therefore, I'm continue to fight for patients, not for money. I haven't taken a new patient in almost 10 years, and I'm getting about half a dozen calls per day. I'm not interested. That is not what this is all about. This is strictly me giving back to this country for all that it has done for me, and I feel compelled to give back. How else am I going to give back? Because the only thing I really can give back is knowledge. And I'm sharing my knowledge with you, not because I want to make money out of it. I'm not interested. I have turned down multiple offers to turn this show into a money-making show. I said no, not interested. Couldn't care less. I'm doing this pro bono because I love teaching, and I want to share with you the knowledge that God has given me. That's all I'm doing, okay? People don't like it, that's their problem. This is a free country. I have First Amendment right. Furthermore, in addition to being a physician, I'm also a journalist. I've been doing this show since 1992. That's 27 years. I think I should qualify as a journalist, don't you think? So therefore, and I have First Amendment right on top of that. So, and there's no reason for me to stop. I'm going to do it as long as I can breathe, and I'm continue to fight for patients to get the care they deserve. Medical care is not a privilege; it's a right. Medical care is a right. Health care is a right. People are entitled to it. Okay, people are entitled to it. So therefore, when you agree to give it to them, you have to make sure you give it to them the right way. If you're doing it, you couldn't care less whether you're doing it for free or for money. You have the same responsibility. Once you say yes to a patient, yes is yes, no is no. I say no all the time. All day long I'm saying no, I'm not interested. But when I say yes, you could bet you I'll walk from here to China barefooted to fight for my patient because that's what I believe in. And your silly, stupid attempt to try to shut me up, you're making a fool of yourself and exposing yourself to all sorts of legal problem down the line because all that crap you're doing, I have it all documented, believe me. And one day, you're going to be called to the carpet. Listen, until I see you again, this is Dr. Alcena saying so long and bye-bye.